Thank you to everyone who commented on this topic. Why is stability such an important topic? I think it's because stability is the ultimate goal that we're all chasing as clinicians working in the spine therapeutic industry, in particular back pain. The other reason I think we need to talk about this often is so that as functional movement clinicians, we're all consistent in our language and consistent with our definition of terms. If we are going to be effective as clinicians, we need to be effectively communicating, not just with each other, but with our patients as well. So breaking it down, we can see that the acrobat on the tightrope who doesn't fall off is stable. They are resisting potentially injurious forces. Every part of the musculoskeletal system, all the joints are working together as a system to avoid the force of gravity that will injure them should they become unstable. If we extrapolate back to fundamental principles, we can convert what seems to be a complex problem into a more simple fundamental solution. A joint is stable if the joint and periarticular soft tissues have the ability to resist potentially injurious forces. The joint may be in a concentric or eccentric phase of movement, or it may be isometric, or there may be no muscle activity at all. For example, at rest after a traumatic spinal injury, simply taking the motorbike helmet off an unstable cervical spine can lead to spinal cord injury. This is clearly unstable. If we accept that there are forces involved that may or may not cause pain and injury, we must define stability in the context of capacity and demand. If a patient who sustained a spinal injury lays still and is log rolled, then pain and neural injury can be prevented. So by definition, if that patient has almost no capacity and the demands placed on that patient are very, very low, all they have to do is lie there and be log rolled, then they can remain stable. Clearly, that's not an optimal situation when the interrelationship between the patient's capacity and demand is so dreadful that stability can only be maintained when they're log rolled and lying still. So bringing it back to some more real life situations, just to highlight the point. Let's say, for example, a patient who can't go to work or can't mow the lawn because it hurts their back. By definition, they are unstable if they try to engage in those functional tasks. Or another example would be someone who has lumbar spinal stenosis, and every time they try to walk a couple of 100 metres, they experience severe neurogenic claudication. So they make the conscious decision that they won't walk very far. So in that situation, they avoid pain and disability by keeping their functional demands within the boundaries of their very poor functional capacity. But for most people, they have to go to work and they have to do functional tasks, so they don't have that luxury of reducing functional demands. So with the definition specific to that individual, they are unstable because they continue to experience back pain and disability engaging in their life activities. If they do have the ability to engage in what I refer to as Oprah therapy, they can sit on the lounge all day and watch Oprah and keep functional demands very low, then now we have a situation and a clinical context for that patient where we can say that they are stable because they have changed the functional demands required of them. Okay, so it's clear that stability has to be taken into context with the capacity and demand upon our specific or individual patient. So let's consider that we have a patient that can't engage in OPRA therapy. They've got to go to work. They experience pain and disability arising from their back. We need to regain that for them. And how do we do that? Stability is comprised of 3 factors. These are well described. The active factors, the passive factors, and the neurological control factors. So active factors are essentially our muscle activity. Our passive elements are all of those passive structures, so bone, cartilage, joint capsules, ligaments, tendons, discs. They're our passive factors. And then last but most important is our neural control factors. So that is represented by the central nervous system and the control mechanisms by which we activate our musculature, how we coordinate our muscle contraction during movement. So the more that we can optimize these 3 elements that comprise stability, the greater the likelihood that we're going to restore a patient's stability, and therefore by restoring stability we have a high chance of eliminating their pain and disability. So now we have a common goal as movement clinicians. Our common goal is to re-establish stability, and we're going to do that by optimizing our active, passive, and neural control structures. I optimize the neural control by engaging in functional movement therapy, teaching people qualitatively points of performance of movement for simple activities of daily living. I optimize the passive elements by obtaining an MRI scan, looking at those structures and determining whether those passive structures require any structural intervention. And for me, that would be in the form of a surgical intervention if those passive structures are beyond natural repair. And the active structures are optimized by engaging in strength training, in improving the power, strength, endurance, speed of muscle activity. So I'm sure it's clear to you that the 3 elements, active, passive, and neural control, are interrelated and synergistic in their ability to establish joint stability. If we just focused on strength without the skill of movement, you've just got a strong person moving poorly, and of course that is going to lead to instability, pain, and disability. And vice versa, if we just focus on coordination and have no end muscle activity, then that of course is going to fail as well, because the neural control mechanisms have no ability to execute their motor patterns without the musculature to do the work. And we have an interrelationship as well, whereby high levels of coordination and movement proficiency will build and enhance the health of the passive and active structures. So in summary, I think we all agree that stability is critical for joint health. It is the ability of a joint or a system of joints to avoid injurious forces. Stability needs to be defined in the context and relationship to functional demands and functional capacity. People can reacquire stability by simply doing nothing, and for some people that may be okay. For other people, it's extremely unsatisfactory, and we need to re-establish stability for them. How do we do that? We want to optimize 3 of the elements that comprise stability: the active elements, the passive elements, and the neural control elements. Now, for most people who don't want to become athletes, the most important element that we need to optimize for them is the neural control of movement proficiency, teaching them points of performance for moving in everyday life activities. Achieving that has a flow-on effect of enhancing the active and passive elements that comprise stability as well. If our patients are chasing even greater functional capacity, then the rehabilitation method must also optimize those active elements, in particular the musculature, with strength training in combination with neural control optimization. As far as isolated interventions to optimize the passive elements that comprise stability, this is by far a minority component of work that functional movement clinicians will see, but there is a place for isolated passive interventions to the structures such as the discs or the facet joints, and it's really restricted to those people who have had long-standing instability and the joint or the motion segment is unstable and felt to be irreversibly unsalvageable without a surgical intervention that either fuses the motion segment or replaces the disc, or in the situation of traumatic spinal injury, when we can use classifications such as Denis or Punjabi or the AO classification or the Holsworth classification, usually in injuries that involve more than 2 columns of the spine. And in those situations, the passive elements need to be repaired with a passive structural surgical intervention. And in so doing, we can re-establish stability for those patients. But by far, most of our work is going to be re-establishing neural control and regaining some active integrity as well of the musculature. And that's primarily why the functional movement therapy program that I deliver is called NeuroHab, because we are primarily rehabilitating the neural control mechanisms, and I'm relying on that to synergistically enhance the active and passive elements that also contribute to regaining motion segment or spinal stability. All right, thank you very much for listening. Talk to you next time.